Good evening, everyone. On behalf of the IGCP group, I extend a very warm welcome to all our esteemed faculty members and participants joining us today. Thank you for taking time to be with us for this insightful academic session. Today's webinar is on a very and highly relevant topic, which is placenta accreta spectrum prevention and management of man-made disaster. We are honored to have with us and we are really privileged to introduce our esteemed faculty for today's session. First, we would like to invite Dr. Sharda Jan ma'am, who is the host for today's session. She is a senior consultant gynecologist and obstetrician, the director of Life Care Center and Life Care IVF, and expert member of the Ethics Committee, National Medical Commission, Secretary General of the Delhi Gynecological Forum, that is the DGF, and founder and chairman of the National Integrated Gynecology Forum, NIGF. She has made remarkable contributions to women's healthcare, academics, and ethical medical practice. It's a privilege for us to have you with us, ma'am. Next, I would like to invite our co-host for today's session, Dr. Ashmita Rathore, ma'am. She is a consultant obstetrician and a gynecologist specializing in maternal fetal health at Manipal Hospital and Life Trust Multi-Specialty Clinic, Dwarka, New Delhi. She is a former medical director of GTP Hospital, UCMS, former head of the Department of Gynecology and Obstetrics, and in charge of the FNB Maternal Fetal Medicine Program at MAMC LNH, and currently serves as the president of the Delhi Gynecological Forum, Dwarka, 2025 to 2027. Ma'am, we are really delighted to have you with us, ma'am. Our next expert for today's session is Dr. Reva Tripathi, ma'am. She is senior consultant and head of the Department of Obstetrics and Gynecology at Sitaram Bhartiya Institute of Science and Research, New Delhi. She is former head of the Department of Obstetrics and Gynecology at Maulana Azad Medical College, Delhi. We are really honored to have all of us with such expertise with us today. And with that, I would request Dr. Shardajan ma'am to kindly take the session from here. Over to you, ma'am.
Thank you, Arpita. Thank you. It is a great day for we gynecologists in this country. We welcome the Guru of Gurus in obstetrics, Sir Arul Kumaranji, a name synonymous with safe motherhood. He's a surgeon par excellence, academician par excellence, and mentor who has trained thousands to handle the most feared obstetric hemorrhage. When it comes to placenta accreta syndrome, he does not just treat cases. He has taught the world how to prevent a disaster. His mantra is very simple: diagnose early, refer early, bleed less, and today he will teach us all about this. The teacher who made ultrasound science of placenta accreta syndrome and the conservative options part of every resident training. We're all looking forward, sir, for your deliberation and learn from directly from you. So I will request my colleague, Dr. Asmita Rathore, who considers you as mentor in her life. Over to you, Dr. Asmita Rathore.
Thank you, ma'am. Placenta accreta spectrum, which was considered a rare entity 3 decades back, has now become the common obstetric condition with the highest risk of maternal comorbidities and worldwide, with an incidence of around 1 in 800, and the previous cesarean as a risk factor in 90% of the cases. Managing this situation is challenging not only in terms of an professional expertise, but also in terms of logistics, coordination, and thus coming the concept of an multidisciplinary team management with centers of excellence for management of PAS. To speak on this potentially life-threatening condition now, we have an honor and privilege of welcoming Sir Professor Arul Kumaran, who has been mentor to many Indian students, including me. And Professor Arul Kumaran is a Professor Emeritus of Obstetrics and Gynae at St. George's University of London and previously head of the department there. He's a foundation professor of ONG at University of Nicosia since 2013 to date. He has held the prestigious positions of President FIGO, British Medical Association, and RCOG. Has publication of 38 books and 325 indexed articles. He has received national honors of UK Knight Bachelor in recognition of service to medicine by the late Queen in her birthday honors list in June 2009, and Sri Lanka Ranjan National Award in 2019, and Cyprus Active Citizen Award 2019. It's really an privilege and honor for us to welcome you, sir. Over to you for your presentation.
Thank you very much, Dr. Shada Jain, Chair of the Forum, Asmita Ratho, respected Professor, and Reva Tripathi, who will be joining us in a short time. So thank you very much for giving me the privilege of sharing with you some of the ideas on this subject. So there are some propositions which I like to make for my talk because it's difficult to cover the entire spectrum. So I'm not going to go into the diagnostic aspects of ultrasound diagnosis, but I'm going to take the general principles of management given by the Royal College of Obstetricians and Gynecologists and the FIGO. And the proposition which I'm going to make is how to reduce primary and repeat cesarean section, whether the site of surgical incisions can modify the incision, the incidence of placenta accreta spectrum, and any better surgical techniques which can help. And the propositions of management, conservative management, uterus preserving, and definitive hysterectomy, what is in the literature as far as we know. So if we take the papers which I have gone through, one is the Royal College of Obstetricians and Gynecologists, as shown here, placenta accreta spectrum, diagnosis and management. Then FIGO has come out with the conservative management separately, the epidemiology, prenatal diagnosis, and screening. So these are 4 papers I would strongly recommend for you to read to get more information. But most of the information I have given you is published last month by the Royal College. It was accepted in March 2026, the guidelines, and published in June 2026. So we are just 1 month from the time of this publication of the paper, Placenta Previa and Placenta Spectrum, Diagnosis and Management. So I have taken extracts from this paper and added some of the material which I had. So what do they say? Women at high risk of placenta spectrum, accreta spectrum at birth with a previous history of cesarean birth presenting with anterior low-lying placenta or placenta previa should be identified at the first antenatal appointment and provided with care plan, including screening for ultrasound signs associated with placenta accreta spectrum at 18 weeks with the ultrasound examination. And where ultrasound imaging expertise, including transvaginal scan, is available, routine MRI is not recommended in the evaluation of women with high probability of PAS birth. So we don't have to worry about magnetic resonance imaging as far as the college goes. Women with a high risk of PAS who are identified at 18 weeks should be assessed by a multidisciplinary team in a specialist center who manage complex cesarean sections. And the timing of birth with a high probability of PAS should be tailored according to antenatal symptoms and placental location. So first is to get a multidisciplinary team wherever it is, and then to identify when to deliver. And in the absence of risk factors for preterm birth or antenatal bleeding, planned delivery should be done at 36 to 37 weeks. That provides the best balance between prematurity and the risk of operative complications. And delivery of women with high probability of placenta accreta should take place in a specific center of multidisciplinary training with expertise in complex obstetric surgery and logistic support for immediate access to blood products, adult intensive care unit, and neonatal support. So all over UK, we are developing specialized center for placenta accreta spectrum. In a similar manner, we develop oncology centers. So we don't expect every single hospital to deliver placenta accreta spectrum, but specific centers which has blood transfusion facilities, adult ICU, neonatal ICU. And attempting to separate the placenta from uterine wall or intentionally incising through the placenta for fetal extraction should be avoided in all women with a high probability of PAS at birth, because the baby's blood volume is only 300 to 500 ml. So if you make an incision and on the placenta, then the baby might get exsanguinated. So it is best to avoid and to go above or below the placenta. There is no evidence to support routine use of prophylactic ureteric stents. However, collaboration with the urologic surgeon advisable, because if there is major uterine remodeling, that means the shape of the lower segment is distended, and there's a possibility of placenta extending into the broad ligament and the lower cervix. And also there is hypervascularity of the bladder shown on cystoscopy, then it is better to have a urological surgeon in case there is any complication. There is insufficient evidence to support the use of any interventional radiology. We used to have interventional radiologists and have a catheter pass into the internal iliac and the anterior and to the uterine arteries, but we don't do that anymore because there is no evidence to support that should be done as a routine. When the placenta is left in situ after the delivery of the fetus, that means you don't touch the placenta, local arrangements need to be made to ensure regular review because they might develop infection or bleeding, and it should be able to be controlled. And there's a role for re-entering the abdomen 6 to 7 days after the primary surgery and completing a total hysterectomy to avoid such complications. Methotrexate should not be used in this context because it acts only against actively dividing cells, and that stage at term placenta doesn't have actively dividing cells. The woman with high probability of PAS birth and a partner should be involved in preoperative decision concerning mode of anesthesia, because they should know we can do it under epidural or spinal, but it may be converted to the general anesthetic if bleeding is severe and the blood pressure drops. So psychological support before and after birth is quite important. And women conservatively manage with uterine preservation surgery should be informed of the high risk of recurrence in subsequent pregnancy, as contraceptive choices should be discussed. So we have to really think whether they should get pregnant at all, and if they do get pregnant, there's a risk of placenta accreta spectrum disorder. Now, if you find it early, the scar pregnancy, then there is a live cesarean ectopic, which means the uterine cavity is seen separately and there is a separate sac extending into the uterine wall, then it can develop major complications, rupture, and give rise to problems. So they should, at this stage, you can treat with methotrexate because that is rapidly dividing cells and it is useful, or otherwise you can do it by suction termination. If necessary, under laparoscopic observation, you can suck the products out. Now we have to think about how to prevent it after listening to all that. And the scar area creates conditions of preferential attachment of the blastocyst to the scar tissue. And so this is more common, as we know, in IVF pregnancies, and in pregnancies there is more scarring. The scar area favors the development of the invasive placentation because the placenta goes in search of the blood supply and you get new blood vessel formation from the bladder base, which has no adventitia but a pulsatile artery with a thin wall. So how can we reduce the incidence? Number one, you got to reduce the primary cesarean section by conservative management of labor. And it's a good opportunity to follow the WHO labor care guide because that considers 5 centimeters as the start of the active phase of labor and gives a lot of time for each centimeter dilatation. For example, 5 to 6 centimeters, they give about 5 hours, 6 to 7, about 4 hours, and so on, instead of 1 or 2 hours for each centimeter dilatation. So primary cesarean section, if you reduce, because majority of sections, repeat sections, are for previous cesarean section. So if you can reduce primary, that's the best goal. And if you reduce the induction of labor, that is again useful. And again, it is useful to use a balloon catheter so that she doesn't get agitated having oxytocin or prostaglandin and being in hospital. You can put a balloon catheter and send her home. So when it drops out, the cervix is going to be much more dilated, and then you can start your induction. Number two, counsel the women who request electricization for non-medical reasons properly. So that you tell the woman you can have electric section, but there is a greater chance of blood loss, infection, and the next pregnancy you might end up with a PA's disorder. So if you counsel those who request for non-medical reasons, you can bring the cesarean section down. Third, you have to promote trial of labor after cesarean section with precaution, because the scar rupture is only 5 per thousand in spontaneous labor, 8 per thousand in oxytocin, and 25 per thousand in prostaglandin induced labor with previous scar. So if you can promote her and you can say, okay, we will let you go into labor, but if you don't go into labor, if you don't want risk of additional risk, we won't use oxytocin for augmentation or induction, then you might convince many women to go through labor. And you can give epidural because the scar dehiscence when the peritoneum distance will give a pain and you can pick it up, but you must have facilities for continuous monitoring and also for immediate cesarean section should there be a rupture. Number four, the site of incision plays an important role, and it is known if you make the primary cesarean section incision 2 centimeters above the bladder reflection, then the scar tissue formation is much less compared to you reflect the bladder and make an incision. And this is very much so if she is in the active phase more than 5 to 6 centimeters dilated, because you'll be cutting through cervical and lower segment fibrous tissue rather than muscular tissue. So we'll look at that very carefully. And closure techniques can be also considered, because if you put locking sutures and single layer locking sutures, then you have a possibility of strangulation of blood vessels and more scar tissue formation. So these are 5 steps to prevent the formation of placenta accreta spectrum disorders. Now, I mentioned about the recommendations to reduce LSCS and mentioned labor care guide, which is now found electronically. It is available and you give more time and consider 5 centimeter. But there are additional things which can be put into use. That is a constant trained birth companion, and Cochrane data review shows that if a mother or sister is trained to adequately hydrate the mother, put her on the side, massage the back, give her pain relief, then she had less cesarean section. So that is something which has to be developed, and more clinical trials are needed on that. And of course, improving people to do assisted vaginal births, because sometimes people do a C-section at full dilatation where the assisted vaginal birth can be provided, and you must become an expert on assisted vaginal birth. And intermittent auscultation using a graphic Doppler, because we say that we need a fetal monitor, but nowadays with the graphic Doppler, which can be found on a smaller machine, we don't have to worry about it. And there's a study called the PREVENT study, which is done in Bangalore and Kerala to see whether these things will work in order to reduce the cesarean section. In addition, as I mentioned, you have to reduce induction of labor. Now, there is a trial which is going on by Professor Shakila Thangaratnam from Chennai, who is working at University of Liverpool, like Robson's 10-grade classification of who gets the cesarean section. This project consists of CY. Why do they have cesarean section? And there's a 10-group classification on that. C-op, that is perioperative interventions prevent problem with the scar. That is cleaning the skin, cleaning the vagina, antibiotics before the cesarean section. And finally, C-non. Instead of doing C-section, can we manage the case with assisted birth? So they have collected nearly 14,000 cases in Tanzania and in India, and we are looking forward to the results to see whether this C-safe project will help in reducing C-section. It is a layered to see baseline collection and then intervention and subsequently what happened in these 2 countries. So these are methods or trials which are going on to reduce C-section, therefore avoiding or recurring of the placenta accreta spectrum disorder. Now, coming to the issue of site of incision, this is by Jose Palacios, who is a well-known placenta accreta surgeon. He says, the uterine damage at cesarean section healed by fibrosis, and if more fibrous tissue, there is less blood supply, and there is traction forces with expanding uterine size, and that causes additional damage, and therefore there is collagen exposure, and the blood vessels tend to go through the placenta fibrous tissue and form major blood vessels, which causes the placenta accreta spectrum disorder. So we can see large defects at the time of cesarean after long labor in the second stage, because when we cut through the lower segment in the second stage, we are cutting through more fibrous tissue than muscular tissue, especially if we put the incision low, because the cervico-vaginal artery perfusion is compromised. You cut through the blood vessels as well. So not only the tissue you're cutting through is more fibrous tissue, but the blood supply is also compromised. And that has been shown by immunohistochemical analysis in the subsequent cesarean by taking a biopsy on the scar. That's more fibrous tissue and incomplete decidualization. Therefore, the placenta tends to eat through and get additional blood supply. So what can we do? So he says, he gives a saying it is not connected with the number of vaginal births, but with multiple section, but large cesarean section scars are due to the way we make the incision. So let us take a picture. If this is the normal cervix, the first one, and second one, when the cervix is not effaced, if you make an incision, it goes to the muscular tissue. But when it is effaced, if you go to the level of the head, there's mostly cervix and lower uterine segment, there's fibrous tissue, which is thin. And if you look at the blood supply again, if you go higher up upon the bladder reflection, there's good vascular supply and good muscular tissue. But if you go a little bit lower, then the fibrous tissue tends to predominate and less blood supply. And if you go near the cervical vaginal area, then it becomes even less. So not only the constitution of the tissue, but also the blood supply is different in the different areas. And it has been shown by vascular infusion studies that is the case. So someone proposed that the morphology of the cesarean section scar in non-pregnant uterus after one elective cesarean, and they proposed that the scar location is the only thing we can modify during surgery, because if she is coming for cesarean, we have to do the cesarean, but maybe the place where we make the surgery can be modified. And so based on that, there is a group from Sweden and Norway who looked at the proposition, that is to take the incision either 2 centimeters above the bladder reflection or reflect the bladder and make it 2 centimeters below the bladder reflection. These are cases who are more than 5 centimeters dilated. And then after they have delivered up to 9 months later, then they did a hydrosonography, injecting water into the uterine cavity and seeing how the defects were. This is what they found based on the trial. So they had 122 patients enrolled, so it's not a big number. 114 were assessed by ultrasound examination after they had the cesarean. Half of them were low incision, 55 were high incision, 59 were low incision. And the large scar defects were seen in 7% if you make a high incision, and in 41% in the low incision. So that is very significant. But when they followed up, there was no significant difference in terms of complications. Half of them, in fact, became pregnant, so they were not worried about another placenta accreta spectrum disorder. So they somehow or other managed the cases subsequently. So there's a question mark. What's the major difference if there's a hole or not? We can still manage these cases. But if you have a smaller defect, then obviously the chance of scar rupture is much less. You can give them an opportunity to go through trial of labor. So this is how the defects were when they went second time and wanted to deliver. If they have made the incision in the lower segment, below the bladder reflection, 2 centimeters below, then the scar defects are thin and big. Now, the question might arise that if you make the incision high, 2 centimeters above the bladder reflection, are we going to lose more blood? And are we going to take more time? And there was a study from Nepal, which studied 50% of the cases with the high incision and 50% with the low incision. And they showed that estimated volume of blood loss in a high incision was 188, and traditional skin lower reflection of bladder and low incision was 330. Maybe these were all after 5 centimeters, and there's a tear in the lower segment. You try to deliver the baby, toe and gave rise to more blood loss. In addition, the duration of the operation was 30 minutes with a high incision because there was less blood loss, whereas it was 45 minutes with a low incision because there was more blood loss and hemorrhage control might have taken more time. So, in other words, making a higher incision 2 centimeters above the bladder reflection gives a better scar, less scarring, and also is faster to do, and also the less chance of more blood loss. So that is something which we have to think in our practice. Now, this is what we do normally at the vesicoperitoneal junction. We tend to incise and push it down and make an incision, and the point we make the incision is thin as fibrous tissue. So in a deeply engaged head, avoid going low down and making an incision on the thin muscle layer. Make the incision higher in the thick muscle and the lower segment for muscular healing. May confer other advantages, less lateral tears, and so at, or near full dilatation. Dissecting down and making the incision may be a problematic thing to do because you might cut into the collagenous cervical tissue. The next issue about the technique, because some people do a one-layer closure, and to keep the uterine segments opposed, they tend to do it a locking suture. So when you do a single layer closure, then you have to apply more tension and you reduce the blood supply. So double layer closure may be less tension on the wound, thus permitting better blood flow. And of course, the other things which we mentioned, prophylactic antibiotics prior to skin incision, change of instrument after rectus sheath closure, so on, can reduce the infection risk and therefore a better scar. Now, when we do a cesarean section or repeat cesarean section, sometimes we see the baby's hair and head through the peritoneal window, and we are very happy to see that because we pinch the small peritoneum with a pickup forceps and then deliver the baby, and we don't want to do anything suture. There's hardly any blood loss, but that's the one which can give rise to scarring again, the scar tissue oppose and give rise to placenta accreta. So if you can freshen the scar with coming the muscles, thickness, and approximate the incision, then you can reduce the incidence of fibrous tissue formation. So the upper leg can be thick and the lower segment can be thin. So you have to alter the way you suture. You suture it like going across crossway rather than directly trying to go up and down and try to get the lower segment properly sutured without tearing. Now, interestingly, Martin Munrocker, who was a professor in Scotland in Edinburgh, who promoted cesarean section, he studied some anatomical specimen and he was promoting lower segment because there was a possibility of infection if you make it higher, and scar rupture is more if you do a midline on the uterus. But he wrote in his textbook, although lower uterine segment is ideal to perform a cesarean, with reduced bleeding and thin uterine wall, the high percentage of elastic and collagen tissue could be the cause of healing problems. So he recognized that even so early as the previous century. Now, coming to surgery to avoid the problem, we have conservative and definitive surgery. So this is from St. George's. We promoted what we call as a triple P procedure. Edwin Chandraran was our lead, my senior lecturer at that time. And we coined the word triple P because we placed an occlusion balloon in the internal iliac and finally into the uterine artery and blew it up if necessary. Then we did an ultrasound in theater to localize the placenta and went above the insertion of the placental, and then we excised the placenta by cutting 2 to 3 centimeters above, allowing space in the lower segment to suture. So it can be shown in a diagrammatic fashion in the lower picture, where we make a ultrasound go above and then cut the uterus even through some of the placental tissue and then suture it after removing as much placental tissue as possible. So that shows placenta is still attached to the myometrium, then excision of the myometrium, leaving 2 centimeter myometrium above the bladder reflection to enable closure. We used a lot of perc clot because there's a lot of oozing, and we put underlying sutures and managed to control the bleeding. That is incidentally a fibroid from the upper lip of the lower segment. So that worked for us quite well. We had good results, and I'll show you the results in a minute. And use of Perclot reduced raw area bleeding, and now there are newer techniques to reduce the lower raw area bleeding. There are a lot of raw area where the placenta is attached. Now, this is the first 50 patients of the. We had a 2 liter blood loss, which is very high. After that, we started using the internal iliac catheter. Average hospital stay was 4 days, and 3 women, 6% developed arterial thrombosis without any long-term complications. And we considered as one of the conservative. If the woman did not want any more children, we decided to do a definitive hysterectomy. Now, conservative management, I mentioned there'll be oozing on the surface, and sometimes people suture the lower segment with the posterior wall of the uterus. But there are other techniques which has been described using helium plasma focused radio frequency, and they can reduce the oozing. And this is how that looks like. Site of placenta accreta prior to fulguration, and after fulguration, the bleeding stops, and then you can suture. So that is one method. You can use Perclot, but it may not work, and this works better, I believe, compared to simple techniques of coagulation. Now, Professor Piley from Kerala has decided, because of the inadequate interventional radio facilities, he used a clamp, which is called the aortic clamp, and he managed to do the procedure with less blood loss. So he put the aortic clamp, does the surgery, and he describes our experience using the novel Piley's aortic clamp in the current series and across multiple centers in India demonstrate that this sizable abdominal aorta can be clamped safely and effectively without retroperitoneal dissection. So that is something I don't have experience with, or my team doesn't have, and that is worthwhile considering. And that looks like that, something like an Alice's faucet, but the end is blunt, and you don't have to dissect the aortic peritoneal area. You can put over that and can be applied without retroperitoneal dissection, making easier for ONG use. Now, if you are going to do a hysterectomy, it is always best not to give oxytocin to allow placental separation partially or completely, and then it won't completely separate, but might do partially. But you keep the placenta in situ, because otherwise it will be a torrential hemorrhage, and you do a hysterectomy by doing the clamps as usual and taking it out. One of the problems with the hysterectomy is there are new blood vessels formed from the bladder base onto the uterine lower segment. These are finger-like big blood vessels, which are pulsatile, because these are new blood vessels, which are arteries. Looks like vein, but they're arteries. And if it tears, if you're using a sorbonne holder and try to push it to do the hysterectomy, it'll tear and bleed, and it won't stop bleeding because it's pulsatile and it's going. So you have to clamp the vessels and tie them before you get into the removal of the uterus. So each vessel has to be tied separately. And this is how it is done. Pulsatile, absence of media, does not respond to data, needs identification and tying. So Dr. Saha from your own city has done upfront dissection. So instead of waiting for the baby to be delivered, before the baby is delivered, he said bladder first approach, and he has recognized 78 more cases in a single set study. So that has to be commended. And he has published a series showing some beautiful pictures of placenta accreta spectrum disorders and how they tied the vessels, and then went ahead with the surgery and did not have any. And the complications were similar to the one which was tied later on. Bladder injury only 3.8, which is about 3% to 4% in normal series. ICU admission is similar, surgical site infection, burst abdomen, urinary tract infection. So that is something worthwhile for people to go and study from that center to see how that can be done. Now, the only time in St. George's we try to conservatively manage without removing the placenta is if there is extensive bladder invasion, which is usually unusual. We are cut into the bladder sometimes and run into trouble, but if it is extensive bladder invasion or parametrial involvement on the lateral side, it can affect the ureters, which is extremely rare. But in this case, we tend to leave it alone. And then once the vascularity has settled, surprisingly, the vascularity with placenta accreta settles within 3 to 4 days, and you can open up a week later, or you don't have to open up, you can leave it as conservative and manage the case. And that's the only time we prefer not to get into involved. Now, there is something new which is happening in the UK called the OBS UK study, obstetric bleeding study in the UK by Sarah Bell, who is an anesthetist, and Peter Collins, who is a hematologist, and I chair the trial steering committee. And we are looking at postpartum hemorrhages more than a liter, and more than a liter is common with placenta accreta spectrum disorder. And what is happening here is that there is a trigger which sets off fibrinolysis much earlier with placenta accreta spectrum. Also in normal PPHs, it can trigger off. So they consume a lot of fibrinogen, and the fibrinogen level drops very dramatically. So if they are lost more than a liter, we do a viscoelastic method to find out the blood clot formation, which will reveal that perhaps the clot is not forming well because of the low fibrinogen. And right, so the screen has gone back. Okay, I'll keep on talking till it comes. Okay, thank you. So we escalate to see a senior consultant, and we use cryoprecipitate of fibrinogen concentrate, which can be 2 grams of fibrinogen concentrate can be kept in a bottle and a solution to make it up. And we give that before we give to massive blood transfusion, because we use a massive blood transfusion protocol, which is necessary in placenta accreta spectrum. We might give a lot of blood and give rise to additional problem. So we are trying to see whether we can, because cryoprecipitate again is difficult to get, and also we have to warm it up, whereas the fibrinogen concentrate, which is a powder with another solution to make it up, can be kept in the fridge, and that can also help in controlling the bleeding. So we are going to go through some of the recommendations of the Royal College very quickly, summary of the guidelines, and finish the talk. So when women request for plan for non-medical indications, it is quite important for us to mention about placenta accreta spectrum disorders in subsequent pregnancies. This can happen both planned as well as emergency, but unless we tell her that it is very common, then she might medico-legally take action in the next pregnancy. I asked for cesarean section elective, non-medical, but the doctor did not warn me that I can get placenta accreta spectrum next time. That is quite important. That's a starting point. And epidemiology risk factors, we know previous lower segment, anterior low-lying placenta, uterine surgery or trauma, adverse maternal and resulting IVF pregnancies. All these cases, we have to think of doing a scan, and so it is recommended that women with a high risk probability of PAS should be identified in the first antenatal appointment and provided with a care plan, including screening for ultrasound signs associated with PAS at 18 weeks to 20 weeks. I won't give you the rationale for the recommendation. These are the evidence, and the strength of the evidence is given. Some doesn't have good strength because there are no randomized control trials, but it just says, I tell them not to have a cesarean if possible. Then if you find a placenta low lying, then you have to arrange for a scan at 18 weeks. Then if there are cesarean and anterior low lying placenta, you have to decide on where she's going to get the care, antenatal care team, and must have a good ultrasound operator who can predict who is going to get placenta accreta at birth. And the ultrasound features are very clear of there's no thinning of the vesico-uterine interface, multiple lakes, lacunae, and so on. I won't go through that in detail. So field medicine unit where there is expertise should see her again at 28 weeks. And where expert ultrasound, including transvaginal scan, is available, magnetic resonance imaging is not recommended in routine antenatal evaluation with a high probability of PAs. And women identified locally as having high probability of PAs should be assessed by the nearest specialized center with multidisciplinary teams with expertise in regularly diagnosing and managing Placenta previa accreta, and an individualized referral pathway should be agreed. So we have 4 centers in London, which is St. George's is for London Southwest, and Guy's for London East, Southeast, and so on, so that Cardiff as a center, Oxford as a center. So we don't manage in all the hospitals. We send them to those respective hospitals where they can get a multidisciplinary team, including blood transfusion and urologist and so on. Now, the timing of birth will determine whether corticosteroids are to be given. That timing of birth will depend on the antenatal symptoms, whether she has any bleeding, and placental location, whether it's low down. And if they will benefit, then under 35 weeks we give, but after 35 weeks we don't, and try and aim the delivery between 36 and 37 weeks. So in the absence of risk factors for preterm birth and the antenatal bleeding, the planning is 35 to 36, which provides the best balance between fetal maturity and risk of unscheduled birth. Now, optimizing the birth with suspected placenta previa, it should be in a maternity ward with multidisciplinary team with expertise in complex cesarean birth and logistic support for immediate access for blood products, adult intensive care, and neonatal intensive care unit. And a contingency plan must be done for emergency birth should it take place, because if she starts suddenly bleeding or going into labor, there should be an institutional protocol for management of maternal hemorrhage for all women at risk of PA. So we have a number of consultants in the hospital. Not all of them are trained to do this case. So should it bleed, should it happen, then there should be facility or rostered, including oncologists, if they are available to come and help in this particular disorder. But the blood transfusion protocol, the anesthetic protocol is all laid down. So what should be included in the consent when we talk about placenta accreta spectrum? I think we should tell them about the risk associated with birth in general, and for blood transfusion, lower urinary tract damage, and hysterectomy. For example, the chance of damage to the bladder ureter is 3 per 1,000 in normal cases, even with previous cesarean, but this will be 3 per 100, so it's much higher. So we had to mention that's a possibility. Similarly, the blood transfusion incidence is 10 times higher, so we had to mention that. And hysterectomy is most of the time planned, but if you plan to do a conservative surgery, you have to mention there's a possibility of hysterectomy. And those who do not accept blood for religious reasons, we should discuss about cell salvage and interventional radiology so that we can try to block the aorta, the vessels, as soon as possible. And anesthetic method we have to discuss with the woman and the partner, and we have to tell them we can do it under regional anesthesia, but it may be necessary to do general anesthesia if required to us. So if she's bleeding excessively and the blood pressure drops, then it's much better to manage. Surgical approach, then we have to attempt to separate the placenta from the uterine wall that might give rise to bleeding. And so we had to think about delivering via the incision above the upper placental edge rather than separating the placenta, and then deciding whether you want to do on conservative. You have to plan whether you want to do a conservative or definitive surgery with hysterectomy. And the choice of surgical technique would be dependent on the experience of the surgeon and his experience with preserving and surgical techniques. And the expert surgeon should decide how to do that. And you have to get informed consent from the woman how you are going to manage. Prophylactic ureteric stents are not done, but you work with the urologist surgeon. But if there is a bladder involvement, hypervascularity of the bladder, and uterine interface on a preoperative imaging, then you do that. So there are 4 options of surgery: primary hysterectomy following birth of the fetus through a hysterotomy above the placental implantation site without attempting placental separation. That's one which most of the people prefer, but we had to get the consent from the woman and the husband. Number 2, birth of the fetus through hysterotomy above the abdominal implantation followed by partial excision, Accreta, partial myometrical section will repair the uterus. I mentioned we make a 2 centimeter thick lower segment. There might be chorionic tissue there, but we don't worry about it because that gets dissolved after we sutures. There is no problem of breakdown. Number three, birth of fetus without disturbing the placenta and leaving in situ, following by planned secondary hysterectomy 3 to 7 days following primary procedure. And fourth, birth of fetus through an incision above the placental implantation, leaving the placenta in situ, followed by expectant management. Knowing the risk of infection and bleeding, and these are done for severe bladder invasion and parametrium invasion close to the lower segment. Interventional radiology, there's insufficient evidence to support routine interventional radiology, but in cases where they don't accept blood transfusion and so on, it's a good thing to have because you can block the vessels very quickly. So resuscitated endovascular balloon occlusion of the aorta may be used in women diagnosed with PAs who decline donor blood transfusion. They also should give birth in a unit with interventional radiology service. So how are women with unexpected placenta best cared for? I won't go through the details. I mentioned about the blood products, the latest thing about using cryoprecipitate or fibrinogen concentrate to reduce high amount of blood transfusion. And also if there's no facilities for cell salvage, then that would be quite a useful thing to do, to have a stochastic method to find clotting within the theater. Non-surgical expectant management, leaving the entire placenta can be considered when peripartum hysterectomy is unacceptable to a woman for personal reasons judged inappropriate by the surgical team. So you have to speak to them and see where they like to leave the uterus. So it's a big study in France which showed that it is feasible to leave, and only about 50 to 45% will have complications or different by leaving. But the placenta to get expelled might take 3, 6, 9 months until there are spotting and bleeding and discharge. When the placenta is left in situ, then you have to make local arrangements for regular review by ultrasound, and if there is any fever or any discharge, to look for infection. And it might be a chance that you might have to intervene, and because the symptoms don't settle, then you might have to do a late hysterectomy as well. Methotrexate, I mentioned, it is not of value in adult. So post-birth support is important because it's a nightmare. They lose a lot of blood and be anesthesia and they go into the ICU. They need psychological support because a few of them get post-traumatic disorder. They get up in the night and shout because they feel they're under a light and having a surgery done. So identifying the psychological impact of traumatic birth and its long-term consequences is quite an important one. And now we find that women with postpartum hemorrhage, even without placenta accreta spectrum, if they had massive blood transfusion, they tend to have post-traumatic disorder. So we have to look after them carefully. So those who had preservation of the preservation surgery should be informed of the high risk of recurrence in subsequent pregnancies. And finally, there should be a debriefing, not only for the woman and the husband, but also for the team who is looking after, because we have to convey the team back again and see what are we going to expect in this case in terms of immediate complications and late complications, and how can we give the support to the woman and the partner. So that's the final side. It's a big problem. Some proposition, general principles, guidance from the RCOG and FIGO. In terms of prevention, we have to think about primary reduction and repeat cesarean section. So if you have to go active, labor starts at 5 centimeters, give more time for labor to start, reduce induction rates, and by giving Foley's catheter, wait till the cervix is better. And if it is due non-medical reasons request, then counsel them to see whether they would like to postpone and wait because of the possibility of placenta accreta spectrum disorders. Then coming to site of surgical incision, 2 centimeters above the blood reflection seems to be a good idea to reduce the size of the thinning of the scar and better surgical techniques. And surgical techniques not only for conservative surgery, but also for definitive surgery. As I mentioned, tying the blood vessels on the feeding neo vessels from the bladder base, either before surgery or after surgery. Dr. Saha did it before surgery. We do it after surgery, but not to take a soap on hot air, push it down because you get torrential hemorrhage. Of course, you can use B-Lynch or modified B-Lynch compression sutures, balloons, and so on in addition. So in terms of management, you can have uterus preserving or definitive hysterectomy. Thank you very much, and I'll be happy to take any questions.
Sir, it
I think
was extremely wonderful insight of Placenta Accreta syndrome, and I think a lot of new revelations from your past presentations. What I especially liked is that I think the message must be very very clear that Placenta Accreta syndrome patients cannot be delivered anywhere. There are dedicated centers has to be there, as you pointed out that there are 4 centers in UK where they are just like gynae oncology is, they are managed, where multidisciplinary team is available, which is non-negotiable, where you have a team of gynecologists, anesthetists, urologists, interventional radiologists, blood bank, ICU, and neonatology. I think it was superb, and I think it was very interesting for me to know that if we want to really prevent, reduce primary cesarean section rate, and see primary C-section rate. One thing I came to know for the first time that we should avoid non-medical cesarean section done electively. These are the counseling has to be done. That in case if you want it, you invite the trouble next time that it is going to be placenta accreta syndrome. So I think with my remarks, I will ask Dr. Reva to open up discussion. Then Asmita is going to follow it. Dr. Reva.
Thank you, Dr. Sharda. Am I audible?
Yes, yes.
Yes, yes.
Okay, thank you. Very nice lecture, Dr. Arul, as usual. A couple of comments I would just like to talk about. You talked a lot about the site of incision. Conventional, I think we need to modify the site of incision of the cesarean section, the first cesarean, depending on whether you're doing it um, before labor or intrapartum or second stage or whenever. So undoubtedly, you should not be going too low in the cervicovaginal area, but putting it too up either would be a problem, because then you would be inviting the problem of scar dehiscence and other issues. So I think we just need to be a little appreciative that it is not a one size fits all, and if you're doing it
Yeah. So it's 5 centimeters and above cervical dilatation. The recommendation is to go 2 centimeters above. But if it is an elective or early cesarean section, then
another
you can
point, of course, that I uh, liked about was using the cryoprecipitate upfront. I think that's a good point. And of course, cost issues and availability issues may be there with us. But as you rightly said, that it can be used for PPH, irrespective of pass or anything like that. I would just like to ask you a question. What would be your opinion about handling a subsequent pregnancy, a cesarean scar pregnancy that is diagnosed by ultrasound in the early period of gestation? Would you recommend a termination, or would you try and see whether it's exophatic or endophatic, or and then decide what would be your plan of action? Because that could be considered a secondary method of prevention. Of course, one can't argue with decreasing cesarean rates, etc. There's no argument on that issue. But now we are seeing a lot of cesarean scar pregnancies. What would be your opinion about managing them? Because it's not easy actually to terminate a cesarean scar pregnancy also. and on the other hand, you're letting them be for a potential placenta accreta. So, how would you go about it?
Okay, there are a couple of things I just want to put it all together. There are a few questions. The Dr. Sharda Jain's question about 4 centers are only in London, not in the whole of UK. There are centers in
Okay, all
Oxford,
right.
Cardiff. Then in terms of the incision, Reva, I think you went blank a little bit and came back again, is that the reflection of the bladder and incision below is okay for early cesarean sections, elective and cervical dilatation less than 5 centimeters. The studies which are done were for more advanced cervical dilatation, nearly 6, 7, 8 of full dilatation. Those are the ones they advise doing it early. And we also know in practice, if you do it in a thin area and put the hand to deliver the baby, then it tends to tear sometimes, especially on the left side, and give rise to more bleeding. So the advice of making a high incision is only for late cesarean section, not for early or elective. Then in terms of the scar pregnancy, I showed one slide which showed that it's a scar pregnancy, it's better to terminate the pregnancy. Initially, if you don't want to interfere, you can give some methotrexate because those are actively dividing cells. But it may not work because once the fetal heart starts beating, then the effectiveness of the methotrexate is much less. But otherwise, you can do a suction termination carefully under ultrasound guidance, or sometimes people use a laparoscope as well to inspect the cavity and then do that, because that's much less harmful than doing a blind suction termination. And then after they have, and the general advice is you can use a balloon, a Foley's balloon, if she continues to bleed after you finish the suction termination. You can put into the cervix and into the lower segment and blow it up, and that tends to prevent the bleeding. And in terms of the fibroin concentrate, I was just thinking, would it be a good idea for industrialists and the pharmacy companies in India to produce fibrinogen concentrate for the whole world? It might be something wonderful to do.
Good idea. Good idea.
I think it's going to be a challenge to our pharma community, but I'm sure they will do it.
Yeah.
Hopefully, they will take up that challenge. One other question. When I was a student, which is of course decades ago, we used to use
Internet problem. Dr. Asmita, you can take it up.
Thank you, bro,
your
for such
opinion,
an
because
excellent.
Yeah, you had to repeat
I
the
think
question when you were a student and it was
no, about using suturing for cesarean, avoiding the endometrium, because this entire pass is driven by endometrial problems. So nowadays, I think that it's an issue of the technique, and people are not taking and time. Everybody's short of time, and they just put through their stitches. What is your opinion? Should the endometrium be included or should it not? Decidua,
well,
rather.
yeah, usually the endometrium is not full of blood vessels or anything, so you can avoid the endometrium. You can just come underneath the endometrium and suture. But a two-layer closure is more advisable because you don't use tension. And also a continuous suture is useful because it doesn't constrict the vessels supplying the area. So it's a two-layer closure, continuous suture. Avoiding the endometrium would be the ideal one.
Sir, I just
So
wish to ask you that we are old timers and probably we think, that surgeries which we had done 30 years back, 40 years back, 20 years back, they did not have problem of placenta accreta syndrome. This is exploded in the last 10 years. Do you find the similar trend is there in UK, or do you find any country where the placenta accreta syndrome is not there?
Well, I think it's going to be a problem, especially in India, because your section rate has gone from some 2030 to 46% and 64%, very high in many of your cities. And the reason why it might be a problem is actually when it comes to late labor, like 7 8 centimeters, there is a fetal heart ranges are more common. And we didn't have monitoring at that time. We just let them carry on and deliver them vaginally. But now the younger generation might have less patience of waiting or managing conservatively and jumping in to do the cesarean section a little bit early. And when they do the section in late cervical dilatation, those are the ones which give rise to placenta accreta. So I think there might be something about the practice, how the practice has changed, or more cesareans have further dilatation. So maybe it'll be a good idea for each center to study what percentage of women have section at below 5 centimeters and what percentage are above, or even just take a rough idea about what percentage of those who are elective section compared to more than 7 or 8 centimeter have placenta accreta. And I'm sure the late cervical dilatation will be the ones which run into trouble.
But at
I
the
have
same
no,
time, sir, at the same time, I think I repeat what you have said, or I rightly understood. You said elective cesarean should be avoided.
yes, yes. So because once you have elective cesarean, then the next pregnancy might not be the placenta accreta spectrum, but the next time around when they go, they cut into the same area, then they become thinner and more scar tissue formation. So we have to reduce primary cesarean section, repeat cesarean section, and if we have to do primary, and if it is after 5 centimeters, to do it 2 centimeter above the bladder reflection. And then you have to make sure there's good blood supply. And when you do repeat section, if there's scar tissue, to excise the scar tissue and do it.
Nowadays, when we try to dissuade women from doing cesarean, they say that they only, in any case, are planning one pregnancy, so they are not interested in labor. This is a common refrain in the uh, private sector patients who are planning only one pregnancy. So they always just talk about. So there is both sides of the spectrum. Of course, there are some who will do everything to try and have a vaginal delivery, but there are others who will say, I only have to plan one child in my life. I don't want to go into labor. And so the acceptance of a cesarean in society has also become very high now, rather than the family even suggesting to the patient that try for a vaginal. I think that another issue where we obstetricians have been lacking is that we are not talking enough about the advantages of a vaginal birth for the child. And I think that may be a useful angle to follow to dissuade them from going in for an unnecessary cesarean.
I completely agree, because there are a number of studies which have come now saying the incidence of allergic disorders, diabetes,
Right.
asthma, all are increased with cesarean birth babies. So I think that's an area which we have to emphasize to the mothers. Vaginal birth and breastfeeding, that'll overcome a lot of problems. I mean, we are blaming asthma and allergic conditions now to environmental pollution. But if you take a population in the past and the current population and look at the asthma allergy incidence, that seems to
Breastfeeding.
be much more now. And can't be alone environmental things. It has to be how you build the immunity in the individual baby as well.
Asmita, you have to become proactive to make a
Yeah.
comments.
Thank you, Professor, for this wonderful presentation. If you have time, can we take there are a couple of questions in the comments?
Sure, sure.
Yeah. The first question is, will all deliveries before age of 28 years will prevent it? Does incessant uninterrupted menses is causing placenta accreta?
So
Sorry?
it's the question, I couldn't understand the question well. If all deliveries are done before 28 years of age, you mean?
Yeah.
Yeah, so if they have it as vaginal birth, then there is no issue of placenta accreta spectrum disorder. But if they have it at 28 or 32, if it is older age, then the older age and IVF pregnancies has also some connotation about the placenta accreta spectrum. So if they have older age, previous cesarean section, IVF pregnancy, because of secondary subfertility, then we are increasing the risk. So earlier the better, normal birth is the better, and avoiding cesarean section. So I think the question is relevant, that encourage mothers to have the babies early, to have it naturally, and so that they don't need IVF. If they wait for longer, then they need IVF, and that also can give rise to the problem.
And what's the incidence of maternal mortality with PAS?
Yeah, I can't give you the incidence. The only thing I can say is that there was a what is called a segmental study done in Africa, looking for 2 weeks the cesarean section morbidity and mortality across 22 or 28 hospitals. They looked at cesarean section morbidity and mortality, not specifically placenta accreta spectrum, and it was 50 to 100% increase compared to countries like India or Sri Lanka or Pakistan and so on, because the people in Africa, they are partly not trained enough to do cesarean section, but also the women are anemic, and there's no blood transfusion facilities and so on. So that was a study done, must be about 8 or 10 years ago, under Gates Foundation, and they showed that training is quite important. Building up of hemoglobin is important, and make sure there is blood transfusion facilities where they are doing a C-section. So I think the morbidity and mortality will depend on where the C-section is done. Even in India, if you take a remote place, and if they do C-section, especially with the placenta accreta spectrum, it's going to be high. And that's the one reason, as Dr. Sharda Jain mentioned, that we are forming centers, because there are some where it is done in a smaller hospital, and in a hurried way, halfway through the operation, they send the patient to the major hospital. So in one of the points which I mentioned, I didn't go through in detail, that unexpectedly, if you open up and you find placenta accreta, that's placenta is overwhelming in the front segment. And if you don't have facilities in your center, like blood transfusion, experienced surgeon, then close it and then send with the, so that it'll be done in a better center. Because if you start opening and making the incision, then you lose her in half an hour, 1 hour. Whereas if you close it, nothing lost except your pride. Your pride is lost, but the mother is dead.
I think you rightly said, we have to become obsessed about, if the patient has a previous cesarean and the placenta is anterior, it's got to be placenta accreta, you must think and suspect about it. And the
Yeah.
referral, I think, must be made around 28 weeks, 26 weeks. That's the
Sure.
right time to send them away. And then those centers make a dedicated and commitment kind of a thing as far as anemia improvement is concerned. And a multidisciplinary team has to be there, and the components of the team, before surgery, during surgery, everything is important, that what all things you have to keep ready, which cannot be done in an ordinary hospitals where
Yeah.
people are managing cesarean section.
Yeah.
So I think there are a lot of lessons to be learned from your presentation,
Uh,
and all the people who are listening should also know that we will this recording will be available of sir's presentation, and you will definitely hear it 2 3 times, so you will know exactly what all new he has spoken this time. Dr.
Thank you.
Asmita, any last minute comment by you and Reva?
No, I was just saying that earlier when we were I was at Maulana Azad, then a lot of the patients were coming in emergency because they were not been previously diagnosed. I hope now that number, the proportion who are electively being done compared to those that are coming in emergency has been able to be reversed, because there is a greater consciousness about it now. So, because obviously the handling is much better in a planned manner rather than emergency, because emergency would automatically increase the both morbidity and mortality. So that's something that we would need to deal with if it is still persisting. I'm not sure what the numbers would be saying. Any idea, Dr. Smita?
Doctor,
I think
I
numbers
can.
are same, but we are better prepared now. And I would like to add one our experience in such cases when the operating team was not ready. Most of the times we opted the option of delivering the baby and leaving the placenta in situ instead of going in for an hysterectomy, and they do either an elective surgery at a later date or leave it for expectant management. However, I think we don't have any clarity as to how many days should we wait before we go ahead with an elective surgery at a later date. So, any idea, any comments on that, sir?
Sir has pointed it out. It has to be done 6 to 7 days later.
Yeah, that's
But
what the college recommends. That has been the
yeah,
experience. Unfortunately, the Asmita, the evidence is not on randomized control trials. It's based
Yeah,
on
that's
case
it.
study.
yeah.
So but the recommendation is wait for 6 to 7 days and then do it.
Asmita, you're going to hear on the 13th or the 14th of August last 5 year study as far as cesarean section rate and the mortality is concerned. And, Dr. Radhika is going to point it out that whenever people who had come in emergency with placenta accreta syndrome, the mortality had been very, very high.
Very
You
high.
know,
Yeah.
and
That's
the people who are senior people also who have found that giving 20, 30 blood transfusion and with difficulty managing patients of placenta accreta syndrome, once they find, they become obsessed about it and they make a timely referral. So the people, when you make a timely referral to a center where facilities are available, Delhi also has overcome those mortality. But emergency, cots had suddenly, here the mortality is very high, very high. Sir, I want to make a comment. The Fernandez Hospital in Hyderabad. She was telling that for the last 2 3 years, they minus placenta accreta syndrome, the mortality had been zero. But when placenta accreta syndrome was included, the mortality had gone to 5%.
Oh, so it's fine. I think we have to learn about the use of fibrinogen concentrate or cryoprecipitate, tranexamic acid. All those will help. And also mechanical methods of compressing the aorta during surgery, so that if she's bleeding, somebody should put the hand on the aorta and wait till somebody controls the bleeding. So simple techniques will be helpful.
In fact, one lecture can be given what preparations need to be made for placenta accreta syndrome in
Yeah,
dedicated center for which are there. So I
yeah.
think it was absolutely superb. Asmita, wind up.
Thank you, Professor, for such wonderful presentation and sparing your valuable time for us. And we do look forward to your two subsequent lectures also.
Yes.
Thank you so much.
Thank you
Thank you
very
so
much.
much.
Thank you. All the best to you.
Thank
Over to
you.
you, Arpita.
Thank you.
Yes,
Thank
yes. Thank you so much. Thank you, everyone. Before concluding today's session, we have an exciting announcement to all our participants. This webinar is the first talk in the DGF International Speaker Series, jointly organized by the Delhi Gynecologist Forum, IGCP, and the Med Talks. We warmly invite all of you to join for the upcoming sessions featuring renowned Sir with us, Sir Arun Kumaran. And the next sessions are 18 September, 8 p.m. to 9 p.m. Maternal sepsis, stitch in time saves life. And the third one is 27th of November, 8 p.m. to 9 p.m. Preeclampsia, a cardiac disease that needs fourth trimester care. We encourage all of you to please save the dates and please be a part of this enriching academic discussions. So, with that, I would like to thank you once again for joining us, and thanks to everyone, ma'am, sir, everyone for joining. Thank you. Thank you.
Asmita,
Thank you
I
very much.
correct you that it is a second talk of Sir on this platform. So this is second, and then third and fourth will follow. Thank you very much, sir.
Thank you very much. Thank you.
Thank
Thank you. Thank